Good day, everyone. Welcome to today's Health Insurance 101 program. At this time, all participants are in a listen-only mode. Please note this call may be recorded. I'll be standing by if you should need any assistance. It is now my pleasure to turn the conference over to Ms. Ann DiGiulio. Please go ahead.
Thanks, Robbie. As you just said, my name is Ann DiGiulio. I'm the manager of lung health policy here at the American Lung Association. I run our tobacco cessation policy project, which includes doing things like this webinar and offering technical assistance and producing other products and materials that may be useful to you. And if you are interested in more information, you can visit our website, which we will share with you at the end of the screen, at the end of that webinar. I just want to welcome you to this webinar. Before we get started and I turn it over to our guest speaker, Claire, I wanted to just give a quick overview of what a comprehensive cessation benefit is. And this is defined by the Treating Tobacco Use and Dependence 2008 update, all clinically and scientifically backed data. So there are the 5 nicotine replacement medications, which is the gum, patch, lozenge, nasal spray, and inhaler. And then bupropion, which also has the brand name of Zyban. And then varenicline, also with the brand name of Chantix. Additionally, there's 3 types of counseling, which is individual, group, and phone counseling. So that together creates that comprehensive tobacco cessation benefit. And then the one other piece of background information I want everybody to have before we go into this webinar is the 2015 USPSTF, or the United States Preventative Services Task Force, tobacco cessation recommendation. It was an update, and it found, they reaffirmed their 8th grade, that both counseling and pharmacotherapy, so all those 7 medications on the previous slide, are both safe and effective to help smokers quit. And so with that, I'm going to turn it over to Claire Brockbank.
Thank you, Ann. I appreciate that. So my name is Claire Brockbank, and I'm with Segway Consulting. And Segway has been in business for about 20 years, and we do a lot of work with states and CDC and the feds around tobacco cessation and wellness programs as a whole, a lot of it around business and strategic planning. We focus particularly with employers and insurance companies and the public health and the public sector, trying to build a bridge and find common areas of interest and ways to sort of strategically build programs that make sense for both. So I never thought I'd say this when I was young and in college, but I know a lot about health insurance. So that's what we're going to talk about today, is specifically health insurance and its implications for tobacco coverage. So what we'll focus on today is I'm going to spend some time giving you the landscape of health insurance, of private insurance, and employer-sponsored health plans. I'm going to talk about how it impacts comprehensive cessation coverage, focusing on the kind of coverage that Ann just laid out, and talk about how benefit changes occur. So how do you get change to happen when you're talking about the private or employer sectors? And what are some alternatives to changing benefits? If our end goal is access to comprehensive cessation coverage for everyone, what are some different paths to get there when you're dealing with this sector of the market? And so I'm going to assume that's what everybody's on the call for, and if not, now would be a good time to go take a walk or listen anyway and get educated. So the major market segments that I'll focus on, really in our health insurance system, we have private and commercial, and we have government. And the private and commercial consist primarily of group coverage and non-group individual coverage. That's direct purchase, and that's become an increasingly important segment because of the ACA, with more people buying individual coverage and slightly stricter interpretations on what a small group is. The other segment of government includes primarily Medicare and Medicaid, as well as a handful of other government coverages like the veterans, TRICARE, some things like that. So if you look at this next slide, this is an important slide. I'm going to refer to this several times because this is how coverage is distributed right now. And it looks very different than it did 5 years ago. So you have about 45% of the market is public or uninsured. So from Medicaid, Medicare, other to uninsured. And until recently, Medicaid would not have been so significantly larger than Medicare. So again, that's an important thing, and I know many of you are working with your state Medicaid agencies. So that leaves 55% of the market is commercial. And of that, you can see that the majority of that is employer-based. That is still the dominant way to get coverage in this country. But about 2/3 of that employer coverage is self-insured, and 1/3 is insured. And so that's the first thing we're going to really spend some time talking about as we think about Health Insurance 101, is which of these segments we're talking about. So the next slide, when we're thinking about insurance, there's really two key players. There's a lot of players, but the sort of the two key ones, the heart of it, are employers and health plans. And you want to have a perspective on both so that when you're thinking about interacting with the market, you know which one you're talking to and how that might affect your conversation. The key differentiators that I want to talk about a little bit so you are more educated about some of the nuances are insured versus self-insured, the impact of size, and geography. So those are sort of the major things we'll cover. So let's jump in. So that first issue was insured versus self-insured. And the issue here, so you saw that insured is about 1/3 of the employer market, and self-insured is about 2/3. What that means is that if you're insured, or you have an insured book of business, if you're an insurer, that means you are receiving a premium. If you're an employer, you are paying a premium, and that premium is intended to cover the cost of all the care you receive, all the health care you receive as defined in your benefits package, okay? If you're particularly healthy that year, then the health plan, the insurer, does well. If you are particularly sick, they eat the cost of the additional care that if you use more care than they estimated. So essentially that means that the risk for your health and care is being borne by the health insurer, okay? And that premium that they are quoting includes the medical assumptions that they think you'll use, the actuarial, we think you're a 40-year-old female and so you'll likely fit this kind of profile, a profit margin, premium tax. Most states charge a premium tax to help manage their state insurance regulators, and we'll come back to that in a minute. And then a pad for the risk embedded in the premium. Now, one of the things that we've seen is a shift away from being able to look at risk, that estimating your medical costs based on your health profile, because we don't have pre-existing conditions for the most part anymore. So it's really a very focused assessment of how much health care you're likely to use. The self-insured, on the other hand, instead of the health plan assuming the risk for the cost of care, the employer assumes the risk for the cost of care. The employer says, I don't want to pay that premium tax, I don't want to pay that profit margin, and I don't want to pay that extra level of risk buffer that's embedded in the premium. I want to pay for all that care myself, and I'm going to decide what benefits I want to cover, and I'm probably going to interact with multiple different entities. I'm probably going to have a pharmacy vendor, maybe a behavioral health vendor, a wellness vendor. I spoke with an employer, an HR person in New York for a large national company, and he said he managed 56 different contracts all around his healthcare coverage. That's a lot of contracts. So it's a multifaceted program, typically speaking. But the flip side is most employers aren't in the business of healthcare. So while they don't want to pay that premium tax and profit margin, et cetera, neither do they want to go out and create networks and figure out how to pay the claim for your strep throat culture, et cetera. So they typically contract with health plans, those same ones that might be insurance-bearing entities, to pay an administrative services only fee. That's called ASO. And That gives them access to the provider network, to claims processing, reporting, et cetera. Now, for the consumer, they often don't know the difference. Many of you are state employees, and the odds are your state is self-insured because there's a lot of states. It's typically one of the larger employers in the state, and the more employees you have, the more you can spread risk, right? So you may have a card that still says Aetna or Cigna or Anthem, but you carry that even though your employer is self-insured. So for individuals, it's very difficult to know where you fall, how your coverage fits. Does that make sense? So I might have, in Colorado, where I'm from, there's a tiny little symbol on the card that indicates whether it's a self-insured client or an insured client of my carrier. And that is often why people not in the industry use the term insurance very amorphously. And as we're going to talk about today, what you're dealing with, insured versus self-insured, matters tremendously. Okay? So it's interesting because we're seeing a real trend away from towards self-insurance. In 2000, 49% of covered workers were in a self-insured account, and now we know it's about 63%. That's enormous. We know that we're seeing self-insured products being offered by companies with as small as 50 employees. To use an example that might be closer to home, in many states until the last 5 years or so, your Medicaid programs bore full risk, like they were the plan for their Medicaid beneficiaries, and they paid fee for service every time a doctor provided a plan, and so they were bearing the risk. Most states have moved to working with managed care plans because they've essentially said, I don't want to bear the risk anymore as a state. I'm going to pay a flat premium to a managed care plan, and they're going to cover all those costs. So it's an interesting example of a state essentially moving away from bearing risk and passing it on to someone else. Okay, so there are regulatory implications of insured versus self-insured. If you are an insured plan, you are regulated by your state insurance commissioner. And that is what the premium tax typically goes for, is to help fund that regulation and to create pools in case a health plan goes belly up so that individual consumers will still be protected and doctors will be paid. Typically, an insured plan has plan design dictated by somebody but not the employer. So the federal government dictates some coverage levels. The ACA is the big one, and mental health parity is the other big one. Until those two pieces of legislation, very little was set by the feds. The state sets any state individual mandate. So there's a state that we work with that requires coverage of male hair toupees if you suffer from a loss of hair due to a medical condition. That's true only in a few states, but in that state, an insurer has to provide it. So typically those plans are dictated by regulation and the plan deciding what will be attractive in the market. Self-insured plans, on the other hand, the plan design is mostly the employer. The only impact on plan design is by federal requirement. So again, the ACA and mental health parity was a big shift because we weren't used to, large employers were not used to taking marching orders really from anyone, right, in terms of what kind of coverage they wanted to provide. They really made their own decisions. Another thing that's really important here is that there's very limited data reporting requirements. It's mostly tax type requirements. These are what's called ERISA plans, which you may have heard of. And those are mostly labor and tax requirements, very little with respect to true benefit design. There's some equity issues and non-discrimination issues. So in those cases, even if the group of employees is carrying a Blue Cross and Blue Shield card, if it's an ASO entity, your focal point when you're thinking about promoting comprehensive cessation coverage, in that case, is the employer for the most part. They are the decision makers. Okay, so key thing, insured plans regulated at the state level, self-insured plans, very limited regulation to the extent that there is, it's at the federal level. Decision-making authority on benefits sits with the health plan, who has to comply with mandates in the insured world. Decision-making requirements for benefits in the self-insured world sits primarily with the employer. Again, they have to comply with federal requirements. And so I think we said it at the beginning, but we'll take questions all along. So if you have questions, please feel free to type them in. It's a lot of material we're covering and not a tremendous amount of time. So the other thing that matters when you're trying to understand insurance and you're trying to have a conversation about insurance with an insurer or with someone is understanding the impact of group size on health insurance. So there are different rating requirements, so how I can set my premiums, and benefit requirements for small groups versus large groups. So the definition of a small group changed down to 50 employees in 2016. So that it was before it was state discretion from 50 to 100. So they have different requirements if you fall into that small group category. Many of the benefit requirements of the ACA are specific to the small group. Now, what's important to know for you all is that the United States Preventive Service Task Force requirements that Ann went through, those apply to large and small and self-insured groups. So those really apply across the board, okay? The degree of reporting from health plans varies by size. So even if you set aside the issue of insured versus self-insured, a plan will give you different kinds of reports and provide different kind of data and information if you have 1,000 employees than if you have 100. Typically, it's very difficult to get data from plans if you're under a few hundred employees, even if you're self-insured, which in theory should mean you own your data, right? So if I am paying Cigna a monthly fee, administrative services only fee, but I'm the one covering the cost, even in that case, it may be difficult for me to get very much data from the plan if I'm on the small side. So again, when you're asking about data, you have to think about the kind of size environment that you're functioning in. Another thing that matters is geographic presence. So typically in your state or in your service area, you will have both health plans and employers that operate only in their state, some that are regional, and more than likely a number of national, large, multi-state health plans. And each of those functions a little bit differently. So if you're dealing with a single state insurer in your state, that means the decision-making is being done in that state. There's typically strong community ties. It's a very different entity. And if you're talking about a single state employer, likewise, you're dealing with decisions being made in your community, in your state, and so you have a little more flexibility to have a conversation and talk about benefits and coverage because the control aspect is local. Unfortunately, there aren't a lot of those left anymore. So more often we see multi-state employers, and even in a small state, the odds are you've got employees crossing borders or in other geographic areas. So in that situation, coverage decisions are typically made at corporate headquarters on behalf of all the employees. They want uniformity or at least equity. They don't want the perception that you're really lucky if you live in Connecticut and you kind of, get the raw end of the deal if you live in Tennessee. So those decisions, you're going to have to think about how you frame any of your discussions in terms of applicability across the country or across at least the geographic area of the employer. If you're talking about a multi-state or a national health plan as opposed to an employer, again, those decisions are typically made at corporate headquarters. So you see a lot of decision-making resting in Indianapolis or California, Connecticut, the decisions that are being made that will play out around the entire country. So while healthcare is delivered locally still for the most part, decisions about the what and the how are increasingly being made at a national level. So the question I often get when I talk about this is, well then, what's the difference between, Anthem of Colorado and Anthem of Ohio? And what happens there is you have something called a control plan, and I'm not going to go into great detail, but most of these plans have affiliate members, and they're either affiliates with the same name, like Anthem Colorado and Anthem Ohio, or they've partnered so that anywhere you are, you could get coverage if you needed to. But that control plan is based on where the employer's corporate headquarters typically is. So if I'm an Anthem employer, so I'm going to use Anthem as an example. While decisions may be being made in Indianapolis, if my headquarters are in California, I'm probably going to interact with the California Anthem plan as my main point of contact. So it gets very confusing, is the long and the short of it. It's a little bit like a spider web. One of the reasons when you're to know this is that when you're thinking about change at your state level or local level, often state employers and Medicaid are contained obviously within state boundaries, and they often provide a great critical mass or a starting point for making change, because even if I'm a large national employer, if I have to make a change in order to get the contract to serve all the state employees in Ohio, the odds are I'm going to make changes that I then know that I could implement for other employers in Ohio, and so you have a better case, if that makes sense. So we talked a little bit about comprehensive coverage, and again, Anne laid out what that coverage is, basically pharmacotherapy, counseling, and multiple attempts. And remember, the ACA requirements that are driven off of the United States Preventive Service Task Force apply to insured and self-insured groups. That is probably one of the bigger misunderstandings, is that if I'm a large self-insured group, I don't have to comply. You do. So the question is, who is the accountable party for providing those services? Is it the health plan who sells the product, or the employer who buys the product? And again, the question of the day is it different for insured versus self-insured? So again, when you're talking about these kind of coverage parameters, this becomes an important question, and it has caused a lot of confusion in the marketplace for the last 5 years. So if you are dealing with a self-insured entity, so a health plan that is bearing the risk, the health plan is responsible for meeting all regulatory requirements of the ACA as well as other state mandates. They have to sell a product that meets the requirements, and they are subject to review by their state insurance commissioners. They can outsource a component of care, so they might outsource. In Colorado, a lot of health plans outsource the telephone counseling to the quit line because we have a partnership here, but they are still responsible for making sure that those services are there, and that how they pay for those services are included in their rate filings. So it's quite clear on fully insured who is accountable. Now, it doesn't mean different states have different levels of buy-in to the ACA and different levels of capacity, just sheer bandwidth by their state insurance regulators. So oversight will still vary from state to state, but technically it shouldn't. So what about the self-insured? So the self-insured is the sticky wicket, in that employers bear the ultimate responsibility, but they don't, not really their thing. It's why they use ASOs, and they typically rely on their benefit consultant or their agent and or the administrative services entity. So there's a little bit of a who's on first issue with large employers, and you might find that if you're interacting with them and asking about their benefit designs and coverage. In this case, federal regulators have oversight. We talked about that earlier. But there's really no centralized data repository or reporting requirements. So when you try to find out how many self-insured employers offer comprehensive tobacco cessation coverage, there is really no way of knowing from a data perspective, any kind of centralized data perspective. So with that in mind, what drives benefit design? So we're talking about wanting to make sure that people have good coverage. What drives that? Who decides what benefits are covered? We know that in theory the plan is accountable on the insured side and the employer on the self-insured side, but really the answer to that question is it depends on who's driving. And this is kind of a hokey slide, but figured we needed a picture. So the other thing about, and we'll talk about who's driving and how to frame your message depending on who's driving. So, but the other thing that's important to remember is that in those benefits that Anne laid out, tobacco is really very uniquely fragmented. If I have a heart attack, it is really clear that my health plan is responsible for my coverage, and they will deal with the doctors and the ER and the anesthesiologist, and it may be confusing for you, and you may feel like you're getting the runaround at times, but it does all still come back to one source. Tobacco is very unusual in that, so if we think about the three big requirements, screening, right? The USPSTF says all people should be screened for tobacco. So that's the responsibility of the provider because that's who has the interface with the individual. There is no, excuse me, unique billing code for claim submission around screening. So when a plan says, I don't really know how many of my members are screened, that's pretty legitimate. The exception may be group model plans or community plans that are on a common, medical record. So that's one piece. Then there's the pharmacotherapy, the drugs. And most plans and employers who use plans as an ASO rely on a formulary. And a formulary is a grouping of all the drugs that are covered by that plan or by that employer. And they're typically grouped by generic and non-generic, specialty, et cetera. But those have traditionally been limited only to prescription-based pharmaceuticals. And so an over-the-counter gets very difficult to track. Even if you require a doctor to write a prescription for over-the-counter nicotine replacement therapy, it is not typically tracked along with other drug costs, and it is often not reflected in the formulary. And the issue of no copays, which the ACA requires, is not systematized, if you will. And I'm sure many of you followed the ALA's excellent work where they were really tracking within the exchanges how many were offering some of these different drugs, and they ran into the same issue, that it was very difficult to get a good feel for the over-the-counter stuff because it's really not typically something that's owned by a health plan. The counseling piece is the third requirement, and that we know is three different kinds, individual, group, and telephonic. And so individual is probably the easiest in some ways to kind of get a handle on because there's reimbursement codes for individual counseling, so a physician can provide a bill, and there's diagnostic codes associated with tobacco use. The ICD-10, the new coding system that health providers have to use, has multiple diagnostic codes for tobacco use. So and tobacco counseling, excuse me. So that's terrific, but we don't see those codes used very often. For years, the plans didn't reimburse for those codes and hadn't really activated them. Most of them do indicate they reimburse for them now, but the volume is very low. So we suspect that there's a disconnect here between the plans what providers knew to be true in the past, which is no coverage, compared to what may be true now. And so that's an area we can talk about. Group coverage, we find, is the biggest gap in coverage around the country. That's the biggest hole. It's the biggest, if I want to find a group class, it's the most difficult thing to find. And so it's very spotty information and very little ownership of what really constitutes an effective group and et cetera. Could you do an interactive group online, et cetera. The telephone counseling, there's been a very strong historic reliance on public health or ask a nurse type vendors. So again, this is something that means the health plan is not used to owning all these pieces in one bundled entity, if that makes sense. Again, different from a heart attack or breaking your leg, where you may be dealing with somebody casting your leg, but also a physical therapist, et cetera. But the health plan is used to thinking about those and used to recognizing that they own the whole equation. They do not think that way with tobacco, and in many ways that's just a structure, a reflection of historically how it's been provided. So that is a learning curve for health plans, and it's important to keep in mind. Okay. So if you're a health plan and if you're in the driver's seat, what do you care about with respect to tobacco? Actually, what do you care about with respect to any benefit designs? Because we said, how do you make benefit designs? So you care about being compliant with the Affordable Care Act and other regulations. So in your state, you really want to know what kind of regulations are there in place with respect to benefits, mandated benefits. And you can always find that from your state insurance commissioner. They care about performance metrics. And I don't spend a lot of time on performance metrics, but happy to answer questions. But HEDIS, which asks, which is done in a survey form and asks individuals if they were counseled about quitting smoking and informed of their options. HEDIS metrics also cover clinical measures like, HbA1c monitoring and management for patients, et cetera. So they care about those performance metrics because employers look at those. They like benefit design changes that they can push over to somebody else to implement. That's human nature. So if it's something like an employer saying, I don't want to pay for hospital-acquired conditions, they'll make that benefit design change because they can embed it in a contract. It's really up to the hospital to implement. It doesn't mean it's easy, but if they're looking at a risk-bearing product, they want something that will be attractive in the market, so they don't want to add a benefit that nobody really wants. And they want to see a short-term return because insurers aren't used to holding on to their members for more than a few years, and so they don't want to help you quit smoking only to have you go to their competitor across the way and have the competitor reap the benefit. So they're always thinking pretty short-term about any new benefit. If it's an administrative services only situation, then employer demand is sort of the proxy for market attractiveness. And again, administrative simplification. If you can give them something that will be simpler to administer, or you say you've been doing it this way and it's pretty convoluted, we could do it more simply, that's something they care about. So again, when you're thinking about driving benefit design, these are the kind of things that make a health plan more receptive. If I'm an employer, hold on, yep, oh, it advanced. I was having a hard time seeing it on my screen. If I'm an employer, similar to a health plan, I prefer changes that they can ask for and measure but don't have to implement. So again, the hospital-acquired conditions is a great example. I am receptive to things that involve getting some better metrics that have been tracked for me. This is something you can think about with respect to tobacco because the data tracking is really quite poor. And increasingly, I am interested in maybe risk-based payment because, again, all I'm on the hook for is the payment, but somebody else is on the hook for meeting the quality requirements, et cetera. For employers, the value equation is a little bit longer. They typically keep their employees longer. The number one reason employers offer health benefits is to attract and maintain and retain good employees. They say that over and over again. Health and managing costs are distant priorities. It's really that attraction and retaining. So if they're looking at something that will keep you there for longer, that's good. And they're also willing to take a longer time horizon in terms of measuring benefits. So they may be more interested in tobacco cessation because it affects their productivity, it affects lots of other measures than just their medical costs, and they can get those savings in different mechanisms than a health plan can. The other thing that's important for employers is nobody likes making change. So if you can frame and think about benefits in terms of better use of existing benefits and services, and we're going to talk about that a little bit in a minute, but that's super important. If you can look at services for conditions that are already covered and reframing them to improve the outcomes, some of the 618 initiatives that CDC is looking at do that. So things that say, this used to be the gold standard for covering this condition, but it's not anymore, and this is the difference, and this is why it's different, and here's how the evidence is. Again, those are things that are attractive to employers. The key takeaway here is that the employer's wishes dominate. Whether you're a health plan, no matter which of these two slides you're looking at, you have to make a compelling case that is going to be attractive to the health plan's customers, and those are employers. Okay? So one of the things we talked about in this webinar was to talk a little bit about benefit changes. This is a question that Segway gets asked a lot. Why can't we just change the benefit? So first of all, there's that piece that we talked about earlier, remember that pie shape, and only about a third of the employer-covered groups are insured, which means that if you're changing a benefit, unless you're changing it at a federal level, you're going to impact a very small portion of the employees, the covered lives in your state. So there's that piece of it. But this piece may be even more compelling. So this is an example of the time frame if I wanted to have a new benefit effective January of 2018. This assumes that when I start in the summer of 16, the case has already been made. The legislation has already happened, but I know I have to add this benefit or modify this benefit. So in the summer of 16, that's when this case is sort of finally confirmed. Yes, we're going to change it. Then you go into a several-month process of doing internal analysis. How is it going to affect my contracts for providers? How is it going to affect my system? How is it going to affect my rates? How is it going to affect my promotional material? All of those kinds of things in order to inform modifications to your pricing model, okay? And that pricing model varies a little bit if you're self-insured versus insured, but either way, you have to know how is changing this benefit going to affect medical costs, healthcare costs. So that happens in the 6 months following the decision that was made. Typically, to change a benefit. Typically, in the spring, and this is overly simplistic, of course, is when you either do a rate filing, if it's for an insured plan. So rate filings have to go for plans on the exchange, typically have to be in the spring for regulatory approval, or my estimate on how much it'll impact an employer who's adding the service if they're self-insured has to be made. So all of those things happen in the spring. Any systems changes that have to be made have to be done in the spring so that you can be selling in the summer. So now we're selling a full year later because most coverage decisions are made in the summer for an effective date of 1/1 the following year. So if I'm talking to that large employer who has all those different vendors, by early summer, he already knows what the benefits are going to look like for the following January. So you're doing that sales cycle then in order to be ready for fall open enrollment. I suspect many of you have gone through open enrollment in the last couple of months. About 70% of the market does open enrollment in the fall, and that's true on the exchanges too, of course, so that I can pick my plan and have it effective 1/1 of 18. So this is really not an exaggerated case here, but it helps you understand that it is a big deal for a health plan to make a benefit change. And it's a big deal for an employer to make a benefit change too. So they don't come easily. There's a lot of moving parts within a system. So you might want to think about go beyond benefit design changes. So we talked a little bit about this earlier, but if you're looking at interacting with the health insurance market, I would say benefit design is sort of your last resort. I would look at how do you promote better utilization so that employers who are paying for the service get their money's worth. Again, that's an employer concern. I would think about how to reframe existing services. Again, we've learned so much more about chronic condition management and upfront prevention. There's definitely more of a receptivity to that, so you might be able to add components. I would really focus on working with those insurers and employers to create mechanisms for better tracking and monitoring, because you will typically hear from a health plan or an employer, oh yeah, I cover that, but they don't know how many people are using it, and so it helps you make a better case if you can say, let's figure out how many people are using it so we can figure out how to make it work better. And then sometimes I think working with non-health plan partners are a great first place. They're a little more streamlined. So work with the wellness vendor, or work with the Ask a Nurse, or work with some of those other entities that have a strong connection to the health plans and the employers, but are a little less bureaucratic, which is the case for many health plans because they're big. They've become so very, very big, and many of their systems have not kept track. They're working off of old data systems, and so making changes is very hard. So with that, I'm going to open it up for questions and any discussion that folks may have.
Hey Claire, this is Ann. So I will start, and please, it's just a reminder, if you guys can type your questions into the Q&A box. That way I'll ask them of Claire or answer them myself depending on the question. And so the first question that we always get is this webinar being recorded? The answer is yes. It will be posted online in the next week or so, depending on the speed and workflow of our IT team. I apologize, it's right before the holidays, so it might be a little bit delayed. But just a couple of questions that we've had come through so far. So somebody asked about the CPT codes and was curious. They thought that there were some CPT codes, or if there isn't one, could one be added?
That is a great question.
For the screening.
There are not billing codes, at least as of the last 3 months, for screening. And most plans say asking somebody, just like there's not really a billing code for asking someone about their blood pressure, that is part of that sort of preventive primary care office visit. So for the most part, there really aren't. To add a CPT code, gosh, that is a pretty big process. And I would have to get back to you, Ann, maybe on sort of typically the life cycle of a CPT code, adding a CPT code, because it's a really good question.
Yeah, great. Thanks for asking that question.
Mm-hmm.
The next question we've got is, can an individual, registered nurse, certified tobacco treatment specialist bill directly to an insurance company for individual or group counseling?
Typically, so yes, you can, depending on two things. One, if there are any scope of practice issues in your state that restrict what is being provided, so you still have to meet any requirements within your state. And if you're billing a health plan, you have to typically have a contract with the health plan and be credentialed or accepted by the health plan. And so you can't randomly bill. The Affordable Care Act allows plans to deny coverage for these USPSTF services if they're provided out of network. So if you say, but the law requires it, but if you're not a member of that health plan's network, they can deny that coverage. So you want to contact your plans, your local plans, and say, I would like to find out how to become a contracted provider and find out your parameters around tobacco cessation.
Great, thanks. I think the next question, I think I can answer it, but if you want to take the lead at it, it's who do the ACA USPSTF requirements apply to? And so the answer there is USPSTF does not those the tobacco cessation benefit or any of the other preventive service benefits does not apply to Medicare, so that's the over 65 and over category. It does not apply to standard Medicaid. So that's the Medicaid population that had Medicaid and was eligible for Medicaid before the Affordable Care Act was passed. So it applies to almost every private insurance plan except grandfather plans, and then to that new Medicaid expansion plan. So that is who the USPSTF applies to. Claire, do you want to add anything to that?
Just when we say private insurance plans, that's insured and self-insured. It applies to everybody, as Ann said, except grandfathered plans. And grandfathered plans are plans that when President Obama said you can keep your plan if you have it, this was a way to do that, where if you as an employer or a health plan offer coverage and you make no material changes for the worse, so you don't raise prices, et cetera, or take away a benefit, you can keep that benefit. And then you are not subject to these requirements. Again, because most of those are self-insured, it's very hard to get a finger on, a pulse on how many grandfathered plans are left, but the perception is very few.
Great, thanks. The next question, and I will take this one, Claire. What are your expectations of President-elect Trump's plan to repeal the Affordable Care Act? Will the smoking cessation requirements go away? And so if you're like me and read the tea leaves, there has been a lot of talk about repealing the Affordable Care Act, but currently the Affordable Care Act is still the law of the land, and it's a very complicated bill, or complicated law, and many different pieces to it, and repealing it would take many different steps and many different processes, and we really haven't seen any proposal of repeal or repeal and replace and what that would look like. So it's really hard to make any statements now of what that would look like. But we do know that the Affordable Care Act is still the law of the land, and there still are thousands of smokers that need help quitting in the United States. And so we think it's really important to continue to, encourage tobacco cessation coverage, not only because it's currently required, but because it saves lives and saves money. And as soon as there is a plan to repeal and or replace, we're happy to, figure out what that means for tobacco cessation. But right now it's really just reading tea leaves, and it's really hard to do that.
And I would add one thing, and that's that many states, right around the time of the ACA and some before, added their own laws about using USPSTF as a guideline for mandated coverage. So in Colorado, that law requires USPSTF. And so you might want to find out, because I don't know, while the ACA trumps those requirements, if the ACA goes away, I believe that if you're in a state that required that, those requirements would still be in place. So that would be something to maybe explore in your individual state.
Yeah, and Claire, that would be my understanding too. So as long as, and especially if the law preceded the Affordable Care Act, it would most definitely still be in effect. If it was after the Affordable Care Act and tied into it, then you might have some problems. And you're more than happy, I'm not a lawyer, but you're more than happy to reach out to somebody who is, or reach out to Claire or I, and we can try to figure that out with you on a case-by-case basis. Again, the caveat of that. And we've got one more question in our chat box, though, and I'll ask that in a moment, and kind of combine a couple of these questions that we've gotten. So if you've got additional questions or you don't think your question has been answered, please feel free to chat in and remind me, because we've got some more, so that's great. So the next question is, a person covered that should be receiving the USPSTF benefits, if they've got a complaint, what do they do if they don't think that their benefits are covered, or they don't think that they're getting the benefits that they're supposed to be?
That is a great question. They should contact their state insurance commissioner, and state insurance commissioners, for the most part, while they are required to enforce the law, they were typically started with a consumer protection perspective. We talk to state insurance commissioners who say, we assume that all the tobacco is covered because we never hear from people. Never hear about it, so we assume it's all good. So that would be where you would want to go to register that that complaint, if you will. And that is not a bad thing to go, even if you're not sure whether you're insured or self-insured. That's probably your most logical starting point if you're looking at from a sort of a widely, a broad enforcement perspective. If you work for a large company and you're pretty sure you're self-insured, then you probably have to go to your human resources department. You could go back to, and you probably can answer this question sort of, there's 3 different regulators of the ACA, Treasury, Labor, and HHS. And so
yes.
where you would go to register a complaint there. But definitely at your state level, it's your insurance commissioner, and that is how they keep tabs. They get a sense. So if I'm an insurance commissioner and I'm getting a lot of calls about a particular plan, I am more likely to do what's called a market review or a review of that plan. Insurance commissioners are like every other public entity. They are understaffed and under-resourced. So if I'm hearing a lot about a plan, that's the one I'm likely to do a deeper dive inspection on.
Yeah, great. And again, the other caveat to that you brought up with the 3 different regulators, it also depends on, this is assuming that you've got a commercial plan, is to talk to the insurance regulators in your state. But if you've got a Medicaid expansion plan and you think you should be receiving those benefits, that's when you should probably contact somebody at CMS or at your state Medicaid office. So that's where the different regulators come in. And again, there's a lot of information and a lot of different things. And so a lot of different moving pieces. So our next question is what might repeal and delay for the Affordable Care Act mean for smoking cessation coverage? And again, unfortunately, this is where we just don't really have enough information to answer those questions. These are questions I've been grappling with now for almost a month. And again, we can read tea leaves and hear what people say and comment, but we really don't, without seeing what an alternative or a delay would be, we really don't, or a replacement would be, we really can't say what we think it might be. I would obviously hope that smoking cessation, as I'm sure all of us would, be included in whatever happens in the future of the Affordable Care Act. And we will wait and see, and as soon as we have information, we'll definitely be sharing it with you guys, with everybody that is willing to listen. So our next question we've got is from an RN, and trying to see the whole question, I apologize. And so just kind of if you could clarify if the tobacco treatment specialist or the primary care provider that's contracted with the plan, who can actually do the billing?
So again, that's going to vary on, so if I'm in a primary care office and my contract with the health plan, it covers, you know, my, all of the rest of my team, so PCMH practices often have more of an umbrella relationship with the plan, then probably, and you have your own provider number. That is really going to vary based on your scope of practice laws in your state. So if you're allowed to provide that kind of counseling, which I believe is true in most cases, but sometimes you need to be have special, like some mental health qualifications because it's a little antiquated. And then it's really dependent on the health plan contract, how the health plan works. And so you would want to find out, again, let's say you're the primary care provider you work with. If you're billing independently right now for other services, you can probably continue to bill independently for that. If you are not billing independently for anything else you do, then you would probably have to bill through your provider. But again, that's really a contracting question, and unfortunately, and it's the burden on providers. Each health plan does a lot of their own requirements in terms of their provider contracting.
Great, thanks. Claire, do you have any questions or anything else you'd like to add, or questions for me, I should say, before we wrap up?
No, these were great questions, and I know Anna's going to make the slides available, and we'll talk after the webinar about a little more clarity around the CPT code and some of the other coding issues. It sounds like that is, and that would obviously affect everybody's ability to bill as well.
Great. So thank you so much, Claire, for joining our webinar, and thank you everyone for listening. If you've got additional follow-up questions, you should all have my email address, as I was the one who sent out all of the promo, and my email was on that. So if you've got questions, please feel free to contact us. We're happy to continue this conversation and really appreciate you taking your time to be part of it. And we will talk to you later. Bye.